Hello, everyone. This is Nayiri from Low Carb and Fasting. We talk about low carbohydrate diet on this channel. We often talk about diabetes as well. Now, today we have the right person, specialist to talk about diabetes, including type 1 diabetes. So I'm very delighted to have our guest on our channel today. So our guest is Dr. David Cavan from the UK. Welcome to Low Carb and Fasting.
Thank you so much. Thanks for inviting me to speak to you.
Dr. Cavan, you are an author of several books, and we'll mention each and every one of them. They're all dedicated to diabetes. You're passionate about reversing type 2 diabetes, preventing it. You also talk often about how type 1 diabetes can be managed through lifestyle interventions and technology combined together. So we are going to cover all of these topics. Dr. Cavan, would you mind telling our audience who may not be familiar with your work about your professional background?
Sure. So I'm an endocrinologist. I'm a medical doctor specializing in diabetes. And I've worked in diabetes for all of my professional life, which is a long time now. And so I'm based in the UK, and for many years I worked as a consultant endocrinologist in a hospital diabetes department down on the south coast in Bournemouth in UK. And then around 9 years ago, I changed tack and I went to work in Belgium, in Brussels, for the International Diabetes Federation. And that really opened my eyes to the realities of living with diabetes in many countries in the world where we just don't have access to a lot that we take for granted. You know, whether it's medications in type 2 diabetes or technology in type 1 diabetes. Along the way, I became very interested in lifestyle management of the conditions. My training was very much to prescribe medications, but particularly in type 2 diabetes, I began to realize that the medications didn't always make much difference. So that's when I turned to looking at lifestyle, particularly low carbohydrate diets for people with type 2 diabetes. And what was really exciting was that was the time that we began to understand that the condition could be reversed. That's when I started writing books, and I've written a number of books now. I only write books for people with diabetes. Although I talked about low carb in type 2 diabetes for much of my professional life, my focus being a hospital specialist has been type 1 diabetes. So I've worked very closely in all the developments in type 1 diabetes over 25 years now. But again, there I began to realize, probably in the last 10 years, that actually a lot of people with type 1 diabetes, despite the best insulins that we've got, despite the technology that we've got, still weren't always achieving what they wanted. And so I then began to explore and suggest to people that, well, actually, you could use your lifestyle, the food that you eat, as part of your management in type 1 diabetes as well.
Dr. Cavan, there is, with diabetes rates rising globally, there is still misunderstanding in the general public about diabetes. Most of the time people confuse, they don't know the difference between type 2 diabetes and type 1 diabetes. And why don't we clarify that for anyone who doesn't have a background in diabetes but interested in sort of improving their health? Let's just clarify the difference between type 2 and type 1. I do wish they were called something different, completely different. They were given different names.
Yeah, and I empathize with that completely, because what they have in common is they both are called diabetes, and they both have conditions where the blood sugar level is too high. Apart from that, they are hugely different. So let's take type 1 diabetes first of all. Type 1 diabetes is a condition where the body is no longer able to produce insulin. So there is a lack of insulin. Insulin is the hormone that regulates blood sugar levels. And if you have no insulin, then you become very seriously ill. So anyone with type 1 diabetes needs insulin treatments lifelong at the moment. That's the way it's managed. Now, it is an autoimmune disease. That means it arises because the body's immune system has attacked the cells that produce insulin. It's got nothing to do with lifestyle, with being overweight, with being inactive or anything at all. It is purely, if you like, a result of luck or bad luck that your body is in some way triggered to attack those cells, which means you no longer have insulin. We see that with a number of other hormone deficiencies as well. Thyroid deficiency, for example, is really quite common. A similar process, the body's immune system attacks the cells that produce thyroid hormone. But there the similarity ends, because with thyroid deficiency, you just need to take a tablet every day, and that replaces it. As anyone with type 1 diabetes knows, management of insulin and replacing insulin is far, far more complex. So that's type 1 diabetes. In the UK, it accounts for probably 5 to 10% of all people with diabetes. So it is very much the majority in terms of numbers. Okay. And that's because in the last 20, 25 years, there's been a massive explosion in numbers of people with type 2 diabetes. And globally, probably well over 95% of everyone with diabetes has type 2 diabetes. So we have this massive, massive issue in every country all around the world, where numbers of people with type 2 diabetes is increasing at alarming rates. It's hitting the headlines, it's putting pressure on health services and health systems. And so there's a lot of publicity about it. Now, type 2 diabetes is also a condition where the blood sugar level is high. But unlike type 1 diabetes, it's not because of lack of insulin. It's because the body cannot use its own insulin effectively. And that's as a result of modern day lifestyles. And so typically type 2 diabetes occurs in people who've gained weight, either because they have it's what has become an unhealthy diet, or they are physically less active, or both. And quite understandably, people with type 1 diabetes feel very upset if someone says to them, well, it's your fault you've got the diabetes, or you shouldn't be eating that, that's why you've got diabetes, you shouldn't eat sugar, and so on and so forth. So they are very, very different conditions. But in saying that, I would also emphasize that I really don't want anyone to look at someone with type 2 diabetes and blame them for their condition, because all of us, wherever we live, our diet and our lifestyles is dictated by the food that is around us. And what has changed in the last 20 to 30 years is not our genetics. No, so, there's nothing in our genes that's made us more likely to get diabetes, type 2 diabetes. What's changed is the fact that we are surrounded by very unhealthy, very cheap, very hyper palatable, it's called. The food industry makes these products very, very tasty, so we want more of them. And it's a combination of that excess of unhealthy food and the fact that we do everything sitting down now. So even 10 years ago, for us to have this conversation, or for all your viewers to have to watch it, we'd all have to travel to a meeting room and we'd do it live. Now we can do everything from our computers. That is affecting also how our metabolism increases the risk of developing diabetes.
Thank you for clarifying that. And hopefully that will clear some of the misunderstanding that people have about the two conditions. Now, generally speaking, management of diabetes, and that's both types, is also mishandled, I think, by physicians, by diabetes specialists, because type 1s are told, okay, well, so you are taking insulin injections, or if you're lucky enough to have a pump, okay, so you have an insulin pump, so you can eat whatever you want and just cover it with insulin. That is not, in my opinion, I've done it. I've done it, and it didn't help make me a healthier person. And type 2 diabetics are quite often told, well, again, you're on medication, so you can just eat what you want and just take your medications. So, and it is a chronic disease. It's going to get worse eventually, but that's your luck. So how do you handle? I mean, what do you do? How do you treat your? How do you tell them about the lifestyle intervention? Because that's not what every diabetes specialist is doing.
So you're absolutely right, and I put my hand up. I'm guilty. For many years, we were taught, and I was told, that because of the fantastic insulins that we've got now, if you have type 1 diabetes, you can eat whatever you like as long as you give the right amount of insulin. And this particularly came about when the rapid acting analogs first came around. The first one was Humalog. I think that was about 25 years ago. And there are now a number of them, but the drug companies produce all these data which showed it's absorbed very, very quickly. It can bring the blood sugar level down very quickly. You inject it just before you eat, and it doesn't matter what you eat, you just need to give the right amount of insulin. So in theory, that's great. And we would teach that, and I teach that to patients in the education courses and management courses that we ran for people with type 1 diabetes. But it didn't always work. And if you actually stop and think about it, it's pretty obvious that it's not going to work. So thankfully, my pancreas, as far as I'm aware, still works well and normally. So if I eat something, then as soon as my pancreas is able to sense that my blood sugar level is beginning to rise, it will start producing insulin. And it releases that insulin directly into the blood vessel where the glucose is coming from my gut. Okay, and this is a marvelous closed loop system, okay, that works and keeps my glucose levels nice and stable. Or so we thought. Now that people are beginning to use glucose monitors just to try things out, even people without diabetes, we're recognizing that if you have a very high sugar, some food or drink with a lot of sugar in, even if you don't have diabetes, your sugar level can go really quite high. Okay, but I can pretty much get away with it because everything works normally. The difference in type 1 diabetes is that, one, you're not injecting the insulin directly into the vein where the food is coming in. You have to inject it through the skin or infuse via pump through the skin. So it's then got to get through the fat cells in the skin. It's got to be absorbed into the bloodstream, and then it's going to get up to a level within the bloodstream so that it can begin to reduce the blood sugar level. Okay. So that's in terms of how it gets there. Second, the timing. We were told at one point, these insulins are so great, you can actually eat them and they'll work back in time. Well, of course, that's complete nonsense. Because within 15 minutes of eating, your blood sugar level's already going up quite high. If you then inject, then by the time that insulin is from the sugar, the level's gone really high. And so this idea that it works immediately is just not true. So there's the timing, there's the route, but then there's also the amount of insulin. So traditionally, people are taught to count their carbohydrates and inject the insulin according to an insulin to carbohydrate ratio. So it might be 1 to 10. So for every 10 grams of carbohydrate, you inject 1 unit of insulin. It's a good starting point for anyone who wishes to use that approach because it makes the maths more straightforward. But how do you know how many carbs you're eating? It is always only going to be an estimate because no one knows exactly. And then we've got to think, well, not all carbs act the same. Some are absorbed into the gut really quickly and push the blood sugar level up really quickly. So if you were to eat sugar or drink a can of soda, it would go up really quickly. Others, it's much more slowly. So a bowl of pasta, anyone with type 1 diabetes will know a bowl of pasta, your levels might not go up for some time, but then they go up and they go up and they keep going up for several hours. There is no insulin available that is going to manage that unless you have a pump and you have a prolonged or square wave bolus. But then there are things like some white bread or white rice, which is a starch, so it's not sugar, but it's broken down so quickly into sugar that it acts very much like a sugar. And so it's not even a question of versus starches, it's sugars versus some starches and other starches that act differently. And to carry all of that information in your head and to be able to give exactly the right amount of insulin at the right rate at the right time, I think is just impossible. So that's why I started to say to people, look, we've got the best insulins we've ever had. We've actually, even with the technology, and especially with the technology that we've got now, even something like a Freestyle Libre, which shows what's happening to your blood sugar levels. You're giving what we think is the right amount of insulin, but your sugar level's still going up. So I don't think that works. I don't think that's right. And I no longer say to people with type 1 diabetes, eat what you like. Because what I say is, by all means, you can eat what you like. In theory, if you give the right amount of insulin, it will work. But in practice, it's difficult to achieve that. And so you might like to try experimenting by having some meals which have got a lot less carbohydrate in, and just see if that helps you manage your levels better.
I have to reiterate what you said. I've done just that. I've tried to be very clever and smart with my pump and use the square bolus option, or that's basically spreading the insulin over 8 hours, 6 hours, 4 hours. So you're not taking just one big bolus of insulin, you're spreading it. I've tried to be so clever with it, but no matter what I tried, A, didn't work, and B, if it did work, by chance, one day, it did not work the next day. So so type 1 diabetes and matching your insulin intake to your carb intake is just far too complex an issue, because there are too many other variables as well. So I prefer avoiding starches and sugars because it just makes management so much easier for me. I know that a lot of type 1 diabetics are now living the low carbohydrate lifestyle. But we need to address people's fear of protein and fat. I mean, I've heard it over and over again, not only from type 1s, but from type 2 diabetics so if I'm lowering my carbohydrates, what do I put on my plate? I mean, I would love a full plate of food. If I'm not having the potatoes there, what else can I eat? And when I tell them, look, you can increase your protein, that is just not too tiny morsels of shrimp is not enough protein. You can increase your protein, and people are terrified because protein usually comes with fat, and people are afraid because they think, okay, so protein, especially red meat, is going to damage their kidneys or pancreas or other organs. We know that's not true, Dr. Cavan. Can you just tell people that is not true and explain the science behind it?
Okay. Yeah. So just before, I think that just to follow on from what you were saying about how from one to the other, eating the same thing can have a very different effect. What we haven't even begun to talk in terms of insulin dosing is how the time of day affects insulin you need, how stressed you are, whether you're unwell, if you're a lady, what stage you are in your menstrual cycle. All of these things also complexity. So I think that's a really good point to then say, well, okay, wouldn't it make sense to make it easier for you, for your body, the amount of carbohydrate you eat? Because by definition, if you have type 1 diabetes, you have a body cannot tolerate carbohydrates, okay? There are a number of other food differences. There is celiac disease, which is gluten intolerance, people and people with celiac disease, they are told, not even advised, they are told you need to avoid all foods that contain gluten. And you have to be really strict. You need to be very careful. Some people are even advised you need to use different plate knives and forks other people in your house in case there are traces of gluten left on their implements. If you have this intolerance, which is an intolerance to the sugar that's in milk, you are advised to avoid dairy products that contain lactose. So it seems to make sense. If you have carbohydrate intolerance, and type 1 diabetes is a form of carbohydrate intolerance, you need to avoid carbohydrates. Okay? So what does that mean? Well, that means what you can eat anything else that doesn't have sugar, or that doesn't have highly refined carbohydrates. Now, a lot of foods will have a carbohydrate in them. Even leafy green vegetables will have some non-starchy carbohydrates. You can't avoid all carbohydrates, but you can make it much easier for yourself to avoid sugars and to avoid starchy foods or large portions of starchy foods. So what does that look like in practice? Well, a very easy swap is to say, well, minimize the starches on your plate and instead pile your plate up with lots of vegetables, non-starchy vegetables, leafy green vegetables, salad vegetables, as much as you want. That will add up to some carbs, so you might need to give a little bit of insulin for it. But there's going to be fewer calories in all those vegetables than there would have been in a same volume of rice or of pasta. And if you need to lose weight, that's not a problem. That will just help you lose weight. But if you don't need to lose weight, you need to make sure you're getting enough calories in. And so what we need to do is to advise people, well, you need to eat more protein and more fats. But they've been given a really bad name in recent years, especially fats. We've been told in the last 20 to 30 years, fat is bad for us, it makes us fat, it causes heart attacks, it puts up your cholesterol level. But if that's the case, why is it that we've only seen these lifestyle diseases like type 2 diabetes, heart disease in the last few decades? People have been eating fats, largely from animals, but there is some fat in plants as well, as long as we've been around. So the tide is beginning to turn. We're beginning to realize that actually natural sources are not bad for us. Dairy products that for so long we've been told you've got to have skimmed milk or half-fat cheese, or, where they take all the goodness and the taste out of it. Dairy products, there's now a lot of evidence to show that dairy products, even full-fat dairy, is healthy for us. So I say to anyone with diabetes, I don't care what you eat. I want you to eat, well, I do care what you eat, but I want you to eat what you enjoy, as long as you are avoiding sugars and minimizing starches, and as far as possible, eating natural, unprocessed foods or minimally processed foods. And that way, and the other thing about increasing fat makes you fuller. It increases kill. Okay, some vegetables, some butter on oil on your salad, the fat will really make that a filling meal, and so you won't be craving foods. So yeah, feel free. People love it when I say, well, why don't you have cheese if you get hungry instead of instead of a biscuit, or instead of a packet of crisps or chips? And they say, oh, I can't eat cheese. Well, yes, you can. I'd much rather you eat cheese than have a biscuit. So that's fat. Protein is a little bit more complicated. There is anxiety that if you have kidney failure, a large amount of protein puts pressure on your kidneys and can cause problems. However, I've not seen any evidence that people with normal functioning kidneys, that this is a problem, because it isn't. So protein does not cause kidney disease. Okay, period. It's actually very difficult to have a very high protein diet unless you're having concentrated protein shakes. And so I say, yeah, if you're cutting your carbs, you might need to have a higher portion or a bigger size of protein, whether it be meat, fish, eggs, cheese, pulses, wherever you get your protein sources, you might need to have a bit more. That is absolutely fine. It will not harm you. The difference between protein and fat is that fats has next to no effect on blood sugar. And some people will see that some types of fat might have an impact, but protein can have an effect. And if you're having a low carb diet, let's say you're having a big steak with a big salad, so very low carb, but very high protein, the body will turn some of that protein into glucose, and you may well need to manage that with insulin. Okay, but this becomes another chapter of the story, and as you'll be aware that if you're having a high protein load, then you will need insulin, but it causes a sugar rise some hours later. So you don't want to be giving your insulin just before. You will want to delay it, and you may want to use a slower acting insulin, or a prolonged bolus in your pump.
Yeah, I'm so grateful you mentioned that, because I did have a question here. It's actually in my notes about dosing for protein. It's something that I have never heard my diabetes consultant mention, or the diabetes nurse, and I don't think they understand it. They don't mention it because they don't understand. They don't know how much insulin one might need, and of course we're all different, for protein, to cover the protein in their diet. Now my meals are usually protein based, and I have to figure out, I'm still learning, I'm still experimenting, and different proteins seem to have different effect on my blood sugar. So I'm learning that whole concept all by myself through experimentation, and most of the time the insulin I take is actually insulin to cover the protein rather than the carbohydrates, because the carbohydrates will be so low, that like about 5 grams or something, so that they won't make that much difference on my blood sugars, but the protein itself will make a difference. So I'm still learning. It's something new to me, learning how much insulin to take to cover the protein.
So before you ask me another question, I'd like to ask you, how then do you work out how much to give for your protein?
I'm eyeballing it now. I don't calculate, because I think it's just too restricting to calculate and look at how many grams of protein you're having, because once you start doing all the maths, you might be disappointed that what works one day doesn't necessarily work the next day. So I eyeball it, and I'm learning to do a good job with it. So I've discovered, for example, that red meat like steak has a bigger impact on my blood sugars than fish. And the protein that has the least impact is eggs. And that might just be me, and I haven't been able to find out why that might be, but I'm learning. I'm just experimenting. I've been a vegetarian for 30 years. So only last year, in fact, 11 months ago, I started introducing meat into my diet. So this is very new to me. So my HbA1c, in fact, went up from 5.7% to 6.1%. And I was hugely disappointed. My diabetes consultant was not disappointed, and he said, for a type 1, it's still 6.1, but I want to go back to 5.7 and keep eating meat because it's making me a healthier person. I also exercise, I do weightlifting, so I am benefiting from the larger sort of protein portions. But I need to cover it with insulin. It's something I had to learn completely on my own. So,
well, the reason I asked you was to stop you asking me how people should calculate how much to give for protein, because I don't have an answer. So one of my books is to support people with type 1 diabetes, and for that I looked into all the different techniques that people are advised to calculate insulin dosing for protein, and there are lots of different ones. Some are based on calories, some are based on grams of protein, and different amounts. So I like to keep things really simple, and if someone's starting out with this, what I would generally suggest is as you explain, if you're having, say, a big portion of red meat that you know is going to have an effect, don't inject anything beforehand, but at your next meal, or if it's an evening when you go to bed, monitor your glucose level and give yourself a correction dose, as most people with type 1 will be familiar with, and see if that will work. And so that would be step 1. That would then give you an idea as to how much insulin you need to cover that type and that amount of protein. And some people are very happy to do that if their HbA1c is staying stable and they're getting spikes, but they can correct it. They're happy to do it retrospectively. Others who don't want to see that spike happening at all, we want to know, well, okay, but I want to give that insulin to avoid that. When should I give it? And my answer is, well, I don't know. That's for you to find out. Which is really what you're saying. So my first suggestion might be, well, let's say that you have a steak and you find you need to give yourself 3 units as a correction dose. So in theory, then you need 3 units to cover it, but it's going to be over a prolonged period of time. It's going to be delayed. So I'd probably say, well, don't give the 3 units before you eat. Maybe give yourself 1 unit after you've eaten, when you've finished the meal, and give yourself 1 unit. Then check a couple of hours later and maybe give yourself another unit. But doing it in a stepwise fashion, so that you can learn what your body requires. But then it's going to be different. If you're eating a big steak because you've spent the day cycling 100 kilometers, you're not going to need that insulin. So it is also individual. So I can't give a more concrete answer than that, but to people to do it in a stepwise way and to use their common sense and give very small amounts.
May I mention what I do, just something that might be important to the topic here. Usually after a meat-based meal, I see the protein spiking my blood sugars about 4 hours after I've eaten. Generally, roughly, it could be 3 hours, it could be 5 or even 6.
Okay. Yeah.
So, but the interesting thing is, so that's why I've now shifted my evening meal, or I only have 2 meals a day, but the second meal to 4 p.m. because then when protein starts spiking my blood sugars, then I can address it before I go to sleep. I do wear the CGM, the Libre 2. Unfortunately, it doesn't always alarm and wake me up through the night. So I don't want the blood sugar rises at night. So I'd rather address it while I'm still awake. So I have my last meal of the day about 4, latest 5 p.m. So I'm still awake while protein is having an impact on my blood sugars. The other interesting thing is, if I combine steak to cheese, So steak and cheese together could cause a rise in my blood sugars even 8 to 12 hours later. So these are interesting things you can only find out by experimenting and trying and see what works for you.
And that illustrates the fact that fat slows down the absorption of food from the guts. So adding the cheese hugely increases the fat content of the meal, which slows it right down. Yeah. Interesting.
So type 1 is always interesting, isn't it? Because it can be theoretic, and also it doesn't seem to be the same for everyone. I talked to other type 1s. We each have a completely different experience of it.
Yeah, absolutely. And, it could be something very strange. I think someone said, almond nuts, they have a big problem with, or, and so that's why I don't want to give sort of very didactic rules for people, because we are all different, and you can learn, particularly people who have the benefit and are fortunate enough to have continuous monitoring systems, you can learn what your body needs from your own experience.
Now, type 1s who manage their blood sugars as best they can by taking massive amounts of insulin. And I heard from Dr. Ian Lake that there are diabetics who do that, who keep their blood sugar HbA1c in a good range by eating a high carb diet and taking big amounts or large amounts of insulin. So what's the problem with that? If that is something possible, if you can keep your HbA1c at a good level, having big variations in your daily blood sugars, because you're bound to have those variations, ups and downs and ups and downs, but the average, the HbA1c seems to be in a normal, healthy range, then what is it problematic?
Okay, so ideally, and I said that a normal functioning pancreas will keep glucose levels generally at a nice steady state. That's what the body likes and expects. And so, yes, it is possible to have a reasonable HbA1c on a high carbohydrate diet with a lot of insulin, but the risk is that instead of a sort of straight line, that your levels are going up and down and up and down. Now you might say, well, that doesn't really matter as long as you're not going into hypoglycemia. And that's the biggest risk of biggest fear, of course, and the biggest risk of having a lot of insulin. That's true. But then the other thing to be aware is there's quite a lot of evidence that some of the complications arising from diabetes are not just due to high glucose levels, they're due to changing glucose levels and big variations in glucose levels. And one of the commonest problems arising from changing glucose levels is to do with nerve function, because nerve cells in particular are very, very sensitive to changing glucose levels. And people might have a reasonable HbA1c, but if their levels are fluctuating like that, it can trigger symptoms in neuropathic symptoms, pain, or abnormal sensations in their feet, or other nervous system problems. So, but yeah, you might, if you are someone who has type 1 diabetes and you eat a high carb diet and you give a lot of insulin and you can avoid that fluctuation, then that's great. You found a way whereby you are able to match what your body needs with the right amount of insulin at the right time. So in principle, that sounds great. In practice, what often happens in that situation is that over time, people begin to put on weight because they're acquiring a high amount of insulin, and insulin is a fat storage hormone. And as you put on weight, just like people with type 2 diabetes, you become quite insulin resistant. That means you need even more insulin to get the same effect. So over time, you can get this situation where people with type 1 diabetes develop what is called double diabetes. They also have features of type 2 diabetes. They've gained weight, they might be obese, and they're insulin resistant. And that is and I've seen several people who've been in that situation. They may be in their 40s or 50s. They've had type 1 diabetes for 30 or 40 years. And if you look at their weight chart, it's just gone up and up and up and up. And that is already opening to a conversation. What I would say to people in that situation, the only way that I know that you can lose weight if you inject insulin is to inject less insulin. The only way you can inject less insulin without causing your sugar levels to go up is to eat less carbohydrate. So how about making that switch to a lower carbohydrate diet? And a number of patients of mine have done that, and they've lost 15, 20 kilograms in weight just by reducing their carbs. And not necessarily to a very low carb diet, but if you're having 300 grams of carbs a day, which is within a normal limit, actually, between 200 and 300 is where most people in Western societies, how many carbs they eat a day. If you're eating 300 and you halve that to 150, it's still not a low carb diet, but you've halved your insulin and you can achieve significant weight loss.
Type 2 diabetes is prevalent in my own family. And so although obesity isn't, but type 2 diabetes is.
Yeah.
And so that's something I've always been terrified about. So my goal is to avoid developing type 2 as well, or insulin resistance. So I do try and keep my carbs as low as possible so that my insulin intake is low. So I remain insulin sensitive. That takes us to actually fasting, because fasting is something else I do occasionally, despite all my good intentions and efforts. Stressful weeks or anything else that might be going on in my life, I notice that my insulin intake is going up and up, and it's increasing over a week. Sometimes it even increases up to 40%, and that's a massive increase for someone who doesn't have weight issues, who's relatively small. So 40% increase in my daily insulin intake to keep my blood sugars in range is something I'm terrified about. So then I decide to go on a longer fast. I do intermittent fasting. I fast about 18 to 20, sometimes 22 hours a day, varying my diet between 1 meal a day to 2 meals a day. But occasionally I have to go on a longer fast. And to me, I have blogs about it. So not every type 1 diabetic needs to do it, but it is possible. And if you would like to explore that idea, discuss with your doctor, obviously, have their support. And it's a great way to regain insulin sensitivity. That's the only reason I do it, not to lose weight. I don't have any excess weight to lose. But I do it to regain insulin sensitivity. So after about 48 hours of fasting, I'm suddenly requiring only 12 units of insulin per day. And that to me is a sign of insulin sensitivity. So any comments on fasting, Dr. Cavan?
Yeah, so I'm a great fan of intermittent fasting. I have a number of patients who use it as part of their regime. One of the main reasons for doing so is to lose weight and to counter insulin resistance, or as you put it, to increase their insulin sensitivity. And the vast majority are people with type 2 diabetes, where fasting, and in its simplest form, it means missing breakfast and having a 16-hour fast. And to some people, very often people, I'll say, "Oh, are you hungry in the morning? Do you like to have breakfast?" And they say, "No, I only have breakfast because I've been told I must have breakfast." And they find it very liberating when I say, "Well, look, skip breakfast. It's actually good for you." So I have no problem with it. I have no problem with people having 1 meal a day or going on prolonged fasts, as long as they know how to manage the impact of their medications, which in the context of someone with type 1 diabetes obviously is their insulin. So yeah, no issue with it whatsoever. In theory, if your basal insulin is correct, you can have a prolonged fast and it will not cause you any problems. In practice, in a lot of people, they're having too much basal insulin. And if they have a long fast, they will become hypoglycemic. So I would say before embarking on a prolonged fast, do a fast maybe for 12 hours or initially 8 hours during the day, and just watch what happens to your glucose level. If it stays stable, then you know you're quite safe. Your basal insulin will not cause you a problem if you have a longer fast. If you see that after 6 hours your glucose is dipping down, then you need to reduce your basal insulin. It is essential for someone with type 1 diabetes who wants to fast, and I have no problem with it, but they need to be sure that they are not having too much basal insulin before they do it. That's what
I always say the CGM is a great device to have, because you're monitoring your blood sugars and you're making sure you stay in safe range, but also glucose tablets.
Yeah.
Have them with you at all times, because you are going to drop low until you find out what works for you, how much basal insulin works for you.
And it's great talking about CGM, and in the UK now, anyone with type 1 diabetes can access at least a Freestyle Libre and possibly another one. I'm just very aware that, we're very fortunate. If you're in the UK, we all complain about the National Health Service, but having worked in countries where people can't even get insulin without paying a huge amount of money, we actually have a really, really good service. But for most people with type 1 diabetes, they don't have access to CGM. And so, they will still be relying on finger prick blood glucose levels.
Yeah. I'm grateful that the NHS actually started funding my CGM. I self-funded it for 4 years before suddenly they decided to fund it for me. We are going to talk about your books now, Dr. Cavan, each and every one of them. And I do urge my audience to go to Amazon, and you can find all of them on Amazon. Tell us about your books, Dr. Cavan.
Well, I don't want to talk about each and every one of them because some of them are already a bit out of date. But if we start off with people with type 1 diabetes, now it just occurred to me, I don't know if when I show that, the book is in reverse, or if you can read it the right way around.
We can read it the right way around.
It looks okay, excellent, because you don't always know. So if you have type 1 diabetes, take control of type 1 diabetes is, if you like, my collected wisdom accumulated over many years of making a lot of mistakes, but hopefully working out how I as a doctor could best help people with type 1 diabetes. It's a few years old now, so it's already a bit out of date in respect of technology, but it covers pretty much everything we've talked about so far, plus a lot more, and goes into a lot of detail about the benefits of reducing your carbohydrates, how you can go about working out how much insulin you want or might need. And then if you're not quite sure what low carb meals look like, then the other book there is the Low Carb Diabetes Cookbook. There are a number of really good quality low carb books out there now. But this is extra special because it's actually been written by a lady with type 1 diabetes called Emma Porter, yes. Who you probably know. She's written over, and they're really great recipes. She's also got a website and a blog, lowcarbkitchen.co.uk. And yeah, it's got my name on it as well because I wrote a few pages at the beginning. But I think that anyone with type 1 diabetes who would like to use, in particular, their diet to help stabilize it, then those books are the ones that I would recommend. For anyone with type 2 diabetes, this book, Busting the Diabetes Myth, was published at the beginning of this year. And it really, again, tells the story over the last 10 years of how our understanding of type 2 diabetes has changed so significantly. I wrote a now called Reverties for people with type 2 diabetes. And at that stage, we knew it could happen. We knew low carb was a good idea. We didn't have a huge amount of evidence. We've now got a lot of evidence. So if you know anyone with type 2 diabetes or pre-diabetes, then I hope this will be very helpful for them. It also includes a lot of first-hand stories of people who've put their diabetes into remission using a low carb approach. And
thank you very much, Dr. Cavan. We're going to wrap this up, but one last thought on the different theories behind what causes type 1 diabetes. You mentioned before that it's not a lifestyle disease. You're not type 1 diabetic because you ate the wrong types of food or because you didn't exercise. So what are the possible causes behind type 1 diabetes?
Well, that's a really difficult question to finish on. It's an easy question. It's a very difficult answer, but in a nutshell, I said it's an autoimmune disease, and that's because the body's immune cells attack the beta cells that produce insulin. So the million-dollar question is, what is it that has triggered that attack? And we don't know the answer, but it is likely to be something. There is something that we are exposed to that triggers that immune attack. Type 1 diabetes, it occurs because the body's immune system attacks the insulin producing cells. And there are lots of theories as to what triggers that attack, possibly a virus infection or exposure to proteins or something in cow's milk or whatever it might be. But not everyone who gets that infection gets type 1 diabetes. So we know that there are some genes that are associated with type 1 diabetes. So it looks as though if you have the right genetic makeup, or rather the wrong genetic makeup, if you've inherited the genes that make it more likely you get type 1 diabetes, and then you are exposed to the trigger, which might be an infection, or it could be infection at a particularly bad time of stress, whatever it is. But that trigger then triggers your immune system to target your beta cells. So it's a combination of genetics and then something in the environment that triggers it, but we don't really know what it is just yet.
Well, I think if we know what gene it is or what the triggers are, then we might address those as a possible cure for type 1 diabetes. Well, but we're a long, long way away from that, I think.
Well, if I tell you that 30 years ago, my MD thesis was on the genetics of type 1 diabetes, and we were looking into those genes. 30 years later, we know a lot more, but we still don't know the answer. You're absolutely right. We need that information, but it seems the more we find out, the more we need to find out.
Well, while we're waiting to find out, we can all adopt healthy lifestyle, whatever that may be for you, and try and keep our blood sugars in a normal range in order to avoid diabetes-related complications, which are numerous. Would that be a good message to end this on?
Absolutely.
What else would you add to that, Dr. Cavan?
I don't think I would. I think I would just say, reiterate what I said earlier. Type 1 diabetes is a condition of carbohydrate intolerance, and that adopting a lower carbohydrate diet can help you achieve more stable glucose levels. If you can achieve more stable glucose levels, it improves your immediate health and well-being, and it protects you from those complications from the future. So I'd encourage everyone with the condition to think what they can do, not just with their insulin doses, but also with their lifestyle to help achieve that level. But I know it's not easy, and I think anyone who pretends it is really doesn't know what they're talking about.
Dr. Cavan, how can people reach you?
Okay, so the best way of reaching me is via Twitter. I I don't do social media, but I do have a presence on Twitter. So I'm at Dr. David Cavan, or I have an email address, which is info@drdavidcavan.com. And please don't ask me any personalized medical advice, because I can't do that. But if anyone's got any general questions or comments, then I'm very happy to engage.
Thank you so very much for your time today. I'm really appreciative of it. Have a good evening. And once again, thank you very much for your time today.
Not at all. It's been a great pleasure. Thank you.